Hi friends, I am presenting a case of hysteroscopic myomectomy for a type 2 myoma, multiparous, para 2 living to 34-year-old, presented with dysmenorrhea and menorrhagia. Ultrasound demonstrated there was a 2.2 into 2 centimeter posterior right lateral wall fibroid uterus. We can see it was on a diagnostic hysteroscopy. We are showing a normal uterine cavity without any indentation of the endometrial cavity. But ultrasound was showing that there was a submucosal fibroid and a patient had presented with a dysmenorrhea and menorrhagia. So we can see this only this is the small submucosal area, the small indentation of the mucosa on the right lateral wall was seen after reducing the intrauterine pressure from 140 to 80 millimeter of centimeter of water. So now on hysteroscopic resectoscope, we can see a small indentation was seen only after reducing the uterine pressure. So that's a small indentation, we can see that. So that otherwise diagnostic hysteroscopy at 140 centimeter of water was not showing any intrauterine pathology. So after taking a 2 resection by resectoscope, now we are able to see that there is a myoma indenting into the uterine cavity. So we can see that there is a myoma. So this is the evidence that we are dealing with a type 2 myoma, that is less than 50% is indenting into the uterine cavity. To remove the submucosal fibroid of this type 2 myoma needs a little bit expertise. That means we have to nibble the myoma out of the myometrium. We have to, once we really resect the mucosa and the surrounding capsularis of the myoma, myoma usually pops out into the uterine cavity, but it will not be so easy. We can see that there is a myoma. We can identify the proximal and distal limitation of it looking at the texture of the myoma. And after every resection, what we are doing is the proximal limit of the myoma, we are trying to nibble it. We are trying to cut the fibrous pseudo capsule of the myoma so that the intramural fibroid uh, becomes a submucosal. So now trying to reduce the pressure on and off and try to remove the resectoscope and did the uterine massage. After doing uterine massage, so we can see this type 2 myoma become almost like a type 1 myoma. That means less than 50% is in the myometrium. So it has come to the mucosa, submucosa popping into the uterine cavity. Now it becomes easy to remove the myoma. It was not possible in the beginning. So when we did a diagnostic hysteroscopy, we were not able to see any pathology in the uterine cavity. After taking a 2 slice of endometrium, now we are able to see the myoma below the endometrium. And after making a uterus massage, after removing the resectoscope, and we are able to make the type 2 myoma into type 1 myoma. And now we can resect it. And the nibble proximal limit of the myoma is try to nibble it out from the myometrium by cutting the pseudo capsule. So once the pseudo capsule is cut, then the uterine cavity is the only place where it can pop out. Then the myoma will come into the uterine cavity, and now it becomes type 1 or even sometimes if it the properly, if it is massage, if it is nibbled out, it becomes very easy under vision to take out the myoma. So this is the one way of making a type 2 myoma into type 1 myoma and then do the hysteroscopic myomectomy. So this now completes the almost complete of myomectomy is done. Thank you for watching.